started. So thanks for everyone joining today. This is webinar, Learning Network webinar. And today, just as a reminder, to let you know, we are recording this webinar for the purposes of preparing a summary and also for you sharing this webinar amongst other members of your team. Today's topics, first thing we'll do is just a real brief overview of some of the housekeeping items related to using the webinar features. I'll briefly update you on where we are with some of the upcoming webinar topics. And the bulk of our presentation today is going to be presented by Patty Dykes, and she's going to be talking about fall prevention care planning and patient engagement. We'll end the process, or end with open questions and discussion, and we hope you guys, will feel free and comfortable to ask questions or use the chat feature, raise your hand, etc. So, in terms of the housekeeping, just as a reminder, and we've sent out a tip sheet for you all, just to kind of, you can have on hand to refamiliarize yourself with some of the tools. If you have a question, a burning question that you would like to ask, we ask that you use the hand feature that is in the right-hand panel of the WebEx window, sort of towards the bottom of the list of names. If you click on that, it will indicate that you are interested in asking a question. And then we can call on you, unmute you, or you can unmute yourself, etc. The other way that you can use the questions is to use the chat feature. We welcome you to send questions via the chat. The one key thing you want to make sure of is that you send that to all participants, I believe it is. All participants. So you're going to need to scroll down that list and find all participants, unless there's a specific person that you want to send it to. So that's one other way that you can communicate a question to us. The other thing I want to ask is that you please minimize background noise. And if you have your computer speakers on and you've also dialed in, try to make sure that you turn down the volume on your speakers. Otherwise, there will be some background noise. But you can also use the mute option on your phone. Just remember, if you ask a question, that you need to unmute it before you ask that question. All right, so with that, I'll just give you a couple of updates on our webinars coming up in the future. So in our next webinar in February, we're going to be doing a special webinar on the topic of creating and using control charts to monitor fall metrics. I know that this is something that some of our fall cohort hospitals have been doing, but not everyone does it, and that's fine. But what we'd like to do is just do a sort of tutorial on that. So this is going to be led by our QI specialists, who are going to talk about how to use control charts as a way to monitor what your fall metrics are and how they're changing and whether or not it's within the range of normal variability month to month. And then beginning in March and going through May, our plan is to have the hospitals, and I'm sure you've heard about this from your QI specialists, but the plan is to have hospitals, several hospitals each month, provide updates on their implementation efforts. Just a brief update on one or two of the interventions that are part of your implementation action plan, talking about, what you did, why you did it, and how it's gone, any barriers, and sort of preliminary results at this point in time. So those will be coming up in March through May, and you'll be working with your QI specialist to determine which hospitals are going to go first. So we'll only do at most around 3 each month. So we'll be working to generate a schedule for you guys in terms of when your presentations will be. So with that, I would like to introduce Patricia Dykes. Patricia Dykes is, as you all know, one of our standing expert faculty on this project. And she was also involved on the expert panel that reviewed the AHRQ Toolkit. And so we've been really lucky to have her among the group of experts that we have at our disposal to ask questions and engage in these kinds of webinars. She serves as a senior nurse scientist and a research program director in the Center of Nursing Excellence in the Center for Patient Safety, Research, and Practice at Brigham Hospital in Boston. And she's done a lot of research on the link between fall risk assessment with individualized and tailored interventions to prevent falls in the acute hospital setting. And so today she's going to be talking about that as well as strategies for engaging patients in that process. So with that, I'm going to now turn it over to you, Patty. I'm going to just move the ball down to you and let you take it over.
Michelle, good afternoon, everyone, and thank you all for the opportunity to be part of this important network and for the opportunity to present some of the work that our team is doing on patient-centered fall prevention and care planning. So Michelle mentioned I am a scientist at Brigham and Women's Hospital here in Boston. I have a joint appointment in the Center for Nursing Excellence and our Center for Patient Safety, Research, and Practice. I spend most of my time working with nurses and interdisciplinary teams to develop and then test innovations to improve patient safety and to engage patients and families in improving the quality and the safety of care that they receive in our healthcare system. About some of those projects today. So here's an overview of our program today. So we're going to talk very briefly about the evidence related to fall prevention care planning. I'll talk about the advantages of using an electronic health record for fall prevention care planning. And then I'll talk about the rationale for engaging patients in the three-step fall prevention process and how through our research we really came to a place where we really believe if we are going to stop all preventable falls, we do need to engage with the patient and the family. And then I'll review some tools for engaging patients and families in the three-step fall prevention process. So most of you at this point are really fall prevention experts. So you know that most falls are preventable. And preventable falls can be divided up into, according to Dr. Janice Morse's work, accidental falls and anticipated physiological falls. So accidental falls are those falls that are caused by environmental hazards or lapses in judgment. We know that we can prevent these through universal precautions. And then we have anticipated physiological falls. That accounts for about 78% of preventable falls. And these are falls that are caused by the patient's known physiological condition. And these are the falls that we assess for when we do a fall risk assessment. They can be predicted using a valid and reliable fall risk assessment tool like the Morse Fall Scale, like the Stratify, that identifies modifiable risk factors. And then also to prevent falls, though, we need to, based on those modifiable risk factors, we need to implement interventions, and they should be tailored to patient-specific areas of risk. Some falls are not preventable, but luckily this is a very small percentage, about 8%. And these falls are, according to Dr. Morse's work, called unanticipated physiological falls. So these are caused by an unknown or an emergent medical condition. So, for example, you're walking down the hall with a patient who has no history of seizure disorder. They all of a sudden have a seizure and they fall. So you could argue that that fall was not preventable. If you read evidence-based literature on fall prevention, you'll see that fall prevention is really a three-step process that involves fall risk assessment or screening, create tailored or personalized care plans, and then consistently implementing preventative interventions. And we'll go through each of these very quickly. So fall risk assessment, we've gone over this again, and I've attended several of these programs. I presented a program on evidence-based care planning early on. And the fall risk assessment is really the foundation of our care planning. We have to use a reliable, prospectively validated scale. This helps us to identify patients who risk for anticipated physiological falls, and then provides the basis for our tailored or personalized care planning. So any of the assessment that we do, we can use that assessment information to to identify our plan. A second step is tailored personalized care planning. So once we finish our assessment, we review the areas of risk that are identified. We select interventions to address each area of risk. And then we need to communicate the tailored fall prevention plan to all the staff who interact with the patient. We also need to share the plan with the patient and his or her family members. And so it's not enough to just develop a plan, but we want to make sure that it's communicated. And the third step is that we need to consistently implement the preventative interventions. So to do this, all staff should practice universal precautions for every patient every day. And all care team members, and we're including the patient and the family in the care team, they need to be aware of patient-specific areas of risk and what interventions are going to prevent that patient from falling. Tools that can help nurses, patients, family, and other professionals and paraprofessional providers to get on the same page about the fall prevention plan can help us to consistently carry out the three-step fall prevention process and to prevent falls. So that electronic health records can be particularly useful because they can reuse information that we document related to the patient assessment, so the fall risk assessment, and then the electronic system can provide clinical decision support that can directly link each area of risk that's present in any given patient to evidence-based interventions. And so this can improve our efficiency, but it can also ensure that every patient gets an evidence-based plan to mitigate their personal risk factors. We found in our research on using the EHR for care planning that using EHR did improve the fall plan of care documentation. So for the patients where the nurses were using the electronic plan of care, we found that the fall risk status was more likely to be documented according to the protocol. We also found that the plans of care were much more likely to address patient-specific areas of risk, so they were tailored. Unfortunately, we didn't find that there were any differences related to the documentation of completed interventions when we compared what was documented as done on the intervention versus the control unit. And you found this in other studies too, and I think that the take-home message is that we need to remind nurses to document not only what they're planning, but also interventions that they also carry out, because it allows us to collect data from each phase of the nursing process in the ER so that we can continue to build evidence from our practice and better understand the impact of nursing care on patient outcomes. And in the case of fall prevention, we can understand specifically which interventions are most effective based on individual risk profile. Over a few minutes, I'm going to review a couple of projects that our team has done or we're currently doing to improve the likelihood that all patients receive an evidence-based plan care. And so the first project, some of you might have heard about it, I've talked about it in other venues, was the Fall Tips project. So that's tailoring interventions for patient safety, and this was a 2-year mixed method study that was funded by the Robert Wood Johnson Foundation. And we first conducted qualitative work because up to this point, there wasn't an evidence-based intervention plan that had showed a statistically significant reduction in falls in acute care hospitals. So we wanted to go back to nurses, to patients who had fallen in the hospital, to other professional and paraprofessional providers to ask from their perceptions what they think, despite all the work that we've done in fall prevention, that hospitalized patients still fall. And then, based on their experience, what interventions do they think are not only effective but feasible in acute care hospital settings? And so from the results of that work, we built a fall prevention toolkit that we called Fall Tips, and then we conducted a cluster randomized control trial to test this EHR-based fall prevention toolkit to address issues that were identified during the qualitative phase and ultimately to prevent falls. So qualitative works in the first phase, we found that communication related to fall risk status and the plan to prevent falls is highly variable. So what's meant to us is that falls are a communication problem. We found that nurses are consistently conducting risk assessment. They're consistently, developing prevention plans, but the degree to which they are communicating the results of their assessments and the tailored plans that are needed to prevent a fall to other team members, including patients and families, highly variable. And this inconsistent communication was a barrier to collaboration and teamwork. So to prevent a fall in hospitals, we really need to all work together. Also found that nursing team members did not always know, they weren't always aware that nurses were even doing fall risk assessments, and we documented them in the medical record, with physicians asking when nurses were describing their process of fall risk assessment and care planning, physicians, physical therapists asked, you really document fall risk assessment every shift? Or you do this every day? Where do you document it? Can we access this information too? So really, just documenting it in the medical record isn't enough. We have to make sure that all team members have access to that. And then the issue is some of our, one of the limitations of the electronic record is we can't rely solely on the electronic record for our documentation related to fall risk assessment in the plan, because some of the very important members of our team, including our professionals and patients and the families, they don't always have access to the electronic record. So we have to think about not only how do we document and use the advantages of the EHR for tailoring, for making sure we get good evidence-based plans, but then how do we communicate that information at the bedside so it's really going to be useful. What we found was very popular when we were doing our observation work was that very often hospitals use these high-risk for fall signs. On medical units, most patients have a high risk for fall sign, and what the nurses and the nursing assistants told us was that they really weren't very helpful because it just became noise in the environment. That high risk for falls doesn't tell you why the patient's at risk. It doesn't give you any information about what you need to do for that patient. To really safely care for a patient with a high-risk fall sign, they often had to leave the room and find out what specifically they needed to do for that patient. So the bottom line is that all stakeholders, that means all of our members, the professional, the paraprofessional members of our care team, patients and the families, they need to have the right information so that they can work together to prevent falls. And this qualitative work, we developed the Fall Tips Toolkit. And so, I summarized on this slide the categories for our Fall Tips Toolkit requirement. And these were the things that we learned from the nurses, from the other professional and paraprofessional providers about what this toolkit had to in order to be useful to them. One of the main requirements was that we had to leverage existing workflows. So all of the nurses and the other team members told us we're already working very hard to prevent falls. You need to not give us additional work, but look at what we're doing and help us learn to do it smarter. We also heard about teamwork and how important that was, and that we had to help with this communication problem. So nurses were already doing the assessment, and in some cases they were creating tailored plans. So we needed to be able to make sure that every patient could get a tailored plan, that this could be available across team members. And then communication. So how do we communicate the tailored plan not only to our professional providers, but also the paraprofessionals and the patient and the family at the bedside? How do we get that information there so that everybody knows how to safely help the patient knows what their role is in fall prevention? Tailoring, that these risk for fall signs are not useful because they don't provide any information about what can be done for each specific patient to prevent falls. At the bedside, you really need to know, for this patient, what do I need to do? So there was a tailoring problem. And then surveillance. We needed to also, again, provide information in the context of the workflow so that a staff member who's walking by a room, if they see a patient starting to get out of bed, they need to know at a glance, is it okay for this patient to get up? Because if it is, we don't want to restrict movement. We want patients to be able to move around. But if it's not safe, they need to know that too. This is a screenshot of the Fall Tips Toolkit that was integrated into the EHR. And on the left-hand side is the fall risk assessment, and so that's the Morse fall scale. And as the nurse clicks off the areas of risk on the left-hand side, the interventions that we had learned through our focus groups to be both effective and feasible in busy acute care or hospital environments automatically check off. So when the nurse completes the fall risk assessment, then the tailored plan that's most likely, according to our research, to prevent a fall based on that individual risk profile is documented. Now, we do know that, we always want to apply evidence based on, what we've learned in research, but we always want to be able to tailor based on what the nurses know about the patient. And so once this tailored plan is completed, the nurse can go in and further tailor or make changes based on what that nurse knows individually about the patient. Plan is filed. It generated 3 different tools. So one was a fall prevention bed poster, or actually this is a fall prevention patient education tool. And so the workflow was that when the nurse filed the assessment, instead of going to pick up a high risk for fall sign, they went to the printer. They picked up this fall prevention plan of care that had some information about why the patient was at risk and which interventions could be needed done to prevent the patient from falling. Oh, so for some reason, all my slides are not showing here. So there were 3 tools. So this is the plan of care. There was also a bed poster and a patient education sheet. And so the workflow was the nurse would take the education sheet and the bed poster. The nurse would explain to the patient about why they were at risk, what the plan was, and then ask the patient, is it okay if I hang this sign above your bed that had specific information about how to prevent the fall, so that my other colleagues will be able to help you. So while we can't see the sign here, it would have these same 4 icons. And so anyone who walked into that room would know, okay, so this person has a history of falls. We know these are patients that are much more likely to fall, or most likely to fall again. If the patient says to me, I have to go to the bathroom, I don't need to leave the room to go ask the nurse, how do I help this patient to the bathroom? Can I leave them in the bathroom? I can see that this patient needs one-person assistance, that they need their walker to walk safely. And I see that the patient has a bed or chair alarm icon, which means that either the patient does not reliably call for help or they're confused. So I know that if I walk them to the bathroom, I can't leave them there. I need to stay with them until they're finished and then bring them back. So we implemented this, or we tested this intervention on over 10,000 patients, and we found that it was very effective in reducing falls. We saw 22% reduction in falls. There were fewer falls in intervention units than the control units. Patients over 65 or older benefited most from Fall Tips Toolkit. We did not see any significant effect with injuries, but we weren't powered to see that. So we had power study on falls, and we needed 10,000 patients to see that. We had a little over 10,000 patients. We needed over 80,000 patients in order to note an effect on injuries, and we did publish our results in JAMA. Lessons learned from the Fall Tips study. So know that overall the intervention was successful. We saw a statistically significant reduction in falls. But, we started this presentation by looking at Dr. Morse's work, who says that over 90% of falls are preventable. And so our question was, why is it that we only prevented 22%? We saw a reduction of 22%. We know that 90% of falls are preventable. Wondered, why is it that, some patients who had access to the Fall Tips Toolkit still fell? And so we did a case control study looking at the factors for patients who were on the intervention units. They had access to the toolkit and they still fell. And we looked at case control, control patients who had access to the toolkit and did not fall. And what we were wondering is, did we miss interventions? Were there interventions that we should have had as part of this intervention that we had missed, that we need to maybe revise the toolkit? And so very carefully at the cases and the controls, and what we found that the main difference between patients who had fallen and patients who had not fallen was that patients who had fallen, the planned interventions were not followed consistently either by the patient or the nurse, and most frequently was the patient. So, for example, the patient was supposed to only get out of bed with assistance, but maybe they got themselves up. They, didn't wait for help, or maybe they were supposed to have two-person assist, and there was only one person that walked them to the bathroom, and on the way they fell, and the one person was unable to, help them in that case. And so our question after doing the case control study was, how do we get patients to consistently follow our fall prevention plan? And it really convinced us that, the difference between that 22% and the 92%, at least some of that difference is probably related to patient engagement and getting patients to really understand why they're at risk for falls, what the plan is to prevent a fall, and what their role is. And so our next steps coming out of the Fall Tips study was to try to develop some tools to engage patients and families more in the three-step fall prevention process. This slide acknowledges our team who worked on the Fall Tips study. And so next couple of minutes, I'm going to talk about another study that we're doing now. This is our Patient Safety and Learning Lab, and one of the projects within it is patient-centered fall prevention. And in this project, we are trying to engage patients and family caregivers, as well as acute care providers, in the design, development, and the testing of a fall prevention toolkit. So with this project, we're using a participatory design approach. So we are using mixed methods. We're using surveys and observations, semi-structured interviews, very similar to what we did with the Fall Tips study. We did include patients and families in that work, but our focus has really been on, looking more carefully at, what is the current state in terms of engaging patients and families in each of the phases of or each of the steps of the three-step fall prevention process. So how often are patients and families actually involved in the assessment? Are nurses just doing it by, in their computers or doing it at the desk, but not really doing the assessment and talking with the patient and reviewing those risk factors with them before developing a plan? So we've done a lot of observations. We have conducted some interviews with nurses, patients, and families, and also done an analysis of all the recordings that we've done of these interviews, and we have identified some end-user requirements for patient participation in the three-step fall prevention process. And, based on the feedback that we got from this early phase, we developed two prototypes. One was an electronic prototype patients could use at their bedside with their nurse, and the other is a paper, and we'll look at both of those. The electronic prototype that we started with for fall risk assessment, and so we integrated this into a portal that we're using already in our acute care environment. And so you can see that we included on the left-hand side here the Morse fall scale, is sort of implied in what these risk factors are. And then on the right side are the icons or the interventions. And so this is really based on, the Morris Fall scale and the fall tips work that we done. And the idea being that, we do first fall risk assessment with the patient and really talk about the plan, how that, what their role would be in that plan, so that the patient would have that with them at the bedside within the portal that they're reviewing anyway, to look at their test results, to look at their medications, etc. We developed a paper version of fall tips, the idea being that not all units have access to portals for patients, and so we wanted to have a way of disseminating the evidence that we had to all units and all hospitals, not just, hospitals that could implement electronic systems with patients at this point in time. And so here again, you can see this is really sort of the patient version of the Morris Fall scale, and then on the right-hand side are the interventions that correspond with the interventions that we used in the fall tip study. And so we took these prototypes to patients, to family members. We have a lot of patient family advisory committees here at Brigham and Women's Hospital. We met with nurses and practice committees. We got a lot of feedback on the tools. And so based on the feedback from the nurses and from the patients and families, and also from our workflow observations, we sort of summarized, what we learned from this process. And one is that nurses lack the awareness of evidence-based fall prevention practices and potential benefits of patient engagement in the three-step fall prevention process. So, we've come to the conclusion that nurses really needed education about, the benefits of engaging patients, that this was not something that they routinely did. Also found that patients lacked awareness about their personal fall risk factors and interventions. So a lot of patients would tell us, oh, yeah, my nurse told me I'm at risk for fall. I need to call for help. Or, that was the most common response. I know I'm at risk for fall, I have to call for help. But when pressed and asked, what specifically, put the risk, most patients could tell you, what their risk factors were. We also found that nurses perceived some barriers to completing fall risk assessment and planning at the patient bedside, that, nurses have a lot to do in the context of a shift, and completing the fall risk assessment with the patient at the bedside takes longer. Now, you get more accurate information, but it's a change in workflow, it's a change in practice. We spent a lot of time with them exploring these barriers and trying to figure out, some ways to overcome the barriers. Also found that, the electronic version of the fall tips that was we had originally developed, that we, where we saw the 22% reduction in falls, didn't adequately engage the patient and family in the process. So the nurse was doing the assessment, but independently, and they were developing and filing the plan, and then, printing the plan and placing that at the patient's bedside. But what we wanted to do with this project, and what we think we need to do, is to push that a little bit further and say, okay, the nurse should do the risk assessment with the patient. The patient should be involved in all three steps. They need to be involved in the assessment so that they really understand their risk factors. They need to be involved in developing this tailored plan so that they can help us to consistently implement the plan. We also, in this particular project, we're partnering with Montefiore Medical Center in the Bronx, and some of the units there, as well as some of the units here at the Brigham, don't have the resources for the electronic fall tip solution. And so we wanted to make sure that we had a range of tools that could be used with so that all patients had access to this evidence, and it wasn't just patients who were fortunate enough to be in a hospital that could have an electronic system that could provide these tip solutions. So based on our interviews with patients and with nurses and families, one of the comments that we got about our original tools, our prototypes, so the electronic prototype that I showed you in the paper prototype was patients didn't really like the icons. We had developed those icons originally with nurses and paraprofessionals because we wanted to make sure that they were understood across wide literacy levels and had not ever validated them with patients. And so we learned from doing our work with the nurses and the patients and the family that we should validate the icons with patients. We also found that the nurses perceived, providing an electronic tool for patients at the bedside, that this was going to be double work, that they really didn't want to document their fall risk assessment in the electronic system and then do it again at the bedside. They also found the user interface unappealing. They thought it was difficult to use. They encouraged us to simplify it. They encouraged us to link the Morse fall scale documentation that they were already doing in their EHR to interventions that were in the patient tool. And then with the paper tool, they felt that the visual display was too busy, it wasn't optimized for the patient and family. They encouraged us to simplify. The other big issue for nurses was that, with the paper tool, if you remember, it was completely yellow. And so while it did have the Morse fall scale on the left and all of the interventions that we had used in fall tips that we knew are effective on the right, there was no way for the nurses to know automatically which interventions went with which area of risk. And so they told us that was, a main downfall of that tool, because there was no guarantee that a patient was going to get an evidence-based plan, that we needed to make it easier for them to see which interventions they could consider for each area of risk. And we were also told we should develop a Spanish version, that, a good percentage of our patients and many of the patients at Montefiore Medical Center are Spanish speakers, and that we should make sure that whatever patient education tools we develop can be used with that population. So this is an example of the forms that we use. We did validate the icons with patients. We went through this iterative process where we had the patient, we went over each icon with patients, with family members. They gave us feedback about what they liked, what they didn't like. They gave us suggestions. Some of them drew pictures for us. And we went through a series of iterations before we ended up with the icons that are on the right side of this page. Now we can look at some of the newer electronic health record design. So one of the things, the requirements was, as I mentioned, the nurses wanted us to link the Morse fall scale in their EHR to the patient tool. And so we are in the process of doing that right now. Montefiore Medical Center is also in the process of doing that in their EHR. So this is the later version of the patient's version of fall tips. And so when the nurse completes their fall risk assessment in the EHR, it automatically populates the areas of risk in the plan in the patient version. And, based on this, so it looks like this patient has all 6 risk factors present, and this is their plan. So the patient can see they need to communicate recent falls. If they click on these buttons, it gives them very specific information about what that means. This patient needs assistance with their IV when they walk. This person must be on, uses a bedpan. They have a cane for walking. The patient must be confused because they have their bed alarm on, the bed alarm icon. We also have a mobile app version of the patient, the electronic fall tips tool for the patient. And so again, this one too will be populated with the Morse fall scale that's done in the electronic health record, and the patient can easily do their plan with their nurse and update it. And the way we're trying to set this up is if they update their plan and they have suggestions for the nurse, that will send a message to the patient in the EHR so that they can make changes. And the paper tool, as you remember, this was the yellow one that we started with. And so this was, so the requirements were to simplify, to add clinical decision support so that they knew which areas of risk were matched with which interventions, and to add a Spanish version. And so here, patients has a history of falls, so, you know, with color to communicate what which interventions went with which areas of risk, so that they would know what to consider. Some feedback that while this was better, it was still, they didn't, you know, they wanted us to use more color. They thought that this was still a little bit confusing and hard to follow. This is the Spanish version, which is also the you know, like our English version. You can see this has the most recent dated version of how we use the color to communicate the clinical decision support. So we did use full color in the boxes to make it easier for them to see which interventions they should be considering for each area of risk. And again, the Morse Fall scale on the left, all the interventions that we had used during the fall tip study on the right. Some usability testing with these tools with nurses. We found that 60% more nurses told us that they'd rather use the redesigned fall tips tool over the existing version, which was the version. 80% of the nurses believe that the redesigned fall tips toolkit is very easy to use, and 50% more nurses were satisfied with using the redesigned toolkit to support fall prevention over the original version. One of our nurses who's using our paper fall tips, one of the clinical care units at the Brigham Women's Hospital. So this is up on one of the medical units. And this is me with one of the nurses and one of the RAs, Emily, who is working on this project with us. So these are some of the tools that we're working on right now. In our future work is really, we'd like to continue to apply this user-centered design cycle to continue to refine this suite of tools that we've developed so far. I've showed you electronic tools, but also paper tools, and really trying to look at ways that we can continue to engage patients through using these tools through piloting. We are hoping to expand the redesigned paper fall tips toolkit to partnering institutions. So right now, I mentioned that we are partnering with Montefiore. There are hospitals that have reached out to us, and we are hoping to continue this partnership. We think that this is a good way to integrate evidence into practice because it's a very simple but user-friendly tool, and we think it can really make a difference in fall prevention if it's used widely. And of course, we'll continue to evaluate our fall and fall-related injury rates and other outcomes. Shot of a lot of the tools that we're working on here now. The picture that's on top is a screen that we're working on that's going in the patient rooms that based on the clinical documentation of the nurse. It shows icons that are specific to that patient. So we're, instead of printing out signs, we can automatically present the icons to the nurses based on their documentation related to each individual patient. So that's kind of next steps for our work. Before we stop and have a discussion, I just wanted to acknowledge our team. So again, I'm just part of the Brigham and Women's Hospital, the Northeastern University Patient Safety and Learning Lab. The fall prevention team is myself, Emily Woong, and the whole group that I have here on this slide. And I thank all of you for your attention and your time, and we have plenty of time now for discussion and questions.
Thank you so much, Patty. The research you guys are doing there is really interesting. So I wanted to open this up. I know one of the things that we ask the hospitals to think about sort of in, the lead up to this webinar was, what are some of the strategies that you are using to engage patients in your fall prevention activities? So I just wanted to see if there were a few hospitals who, well, before we kind of go to that question, I'd like to see if there's anybody who has specific questions about anything that Patty has presented, any of the tools and resources or approaches that they're using. So remember, you'll need to unmute yourself if you have a question. And again, remember, you can type it in or you can raise your hand and let us know. Questions at this time for Patty regarding her presentation.
Liz from UMass, I have no questions at this time.
It looks like Donna, I cannot pronounce your last name, Donna. Donna.
It's Guillaume.
Guillaume, okay.
Hi, Patty. Thank you for this research. This is really exciting, and I've been following your literature, and I've seen you at conferences, so I'm really excited to hear you at the webinar. I have on questions. What we find in the organization is how the engagement of the patient themselves. Have you set up a message how you begin that engagement? Is there like a standard way of telling patients that they're at risk before you even begin to go through the tools?
Hi, Donna. Thank you so much for your question. Thanks for participating in the webinar. So, you know, I think
hold on one second, Patty. Folks, if you could please mute your line if there's any background noise. We have taken the mute off, but we'd like to keep background noise to a minimum. Thank you. So go ahead, Patty.
Okay. I think one of the issues that we have is that, you know, I don't think we have traditionally been engaging patients enough. And so patients aren't used to it and the nurses aren't used to it, right? So we have to sort of bring both along and provide tools that help with the process. And so I think like the paper tool that we developed that I showed you, the idea there is to, when you're admitting the patient, to put out, it's, you know, 11 by 17, to sit with the patient and say, you know, for every patient that comes in, we do a fall risk assessment. I'd like to do that with you now because we've learned that if patients understand why they're at risk and they help us develop the plan, that it's implemented more consistently and they're less likely to fall. So really educating the patient up front, it's an education tool, but no pre-engagement to getting them to use the tool. It's really sort of right in and telling why it's important. Now, that strategy, that process, we've developed based on, you know, years of talking to patients, talking to patient and family advisory committees about, you know, what is the best way to do this? How do we, you know, ensure that patients understand this is important? How can we engage them? And so, you know, I showed two versions of the tool. This has been going on for several years and, you know, had many iterations and have talked to a lot of patients and families about how to do this, and this is the process we've arrived at.
Thank you.
So was part of your question too, whether or not it's helpful in terms of training staff and nurses on doing this engagement, having like scripting available that sort of helps them to introduce the engagement process.
Yes.
Okay. All right. So that's I'm sorry, I misunderstood your question. So it's extremely important to provide training to the nurses, and what we found is that there's a couple things that they need. So there's the engagement piece, but they also need education about how to do the fall risk assessment. So even though, for example, our organization, nurses are doing the fall risk assessment every shift, we found that there was some inconsistent understanding about, you know, how important it was to actually do the risk assessment with the patient because, you know, the Morse fall scale, for example, you can't do that accurately unless you have a conversation with the patient and unless you observe them for many of the areas of risk. For example, history falls. You need to ask the patient and the family if they've fallen within the last 3 months. And based on what they tell you, you need to, put that into your plan. So if the patient tells you, oh, yes, I fell last week because, I got up quickly and I started walking and all of a sudden I collapsed, So maybe based on that, you might decide with the patient, at least in the beginning while you're here, how about if we put down one person assist for you to get out of bed, and you put on your light, will help you. And if things change, we can change your plan. Or, when you're doing a gait assessment, you need to be able to distinguish between a weak gait and an impaired gait, and you can't do that unless you actually watch the patient walk. They need to be able to do that with their walking aid. So, you can't just look at what has been done previously or look up the answers in the chart and be able to do a Morse-Fall scale. The other one, mental status. For the Morse-Fall scale, it's not just is the patient confused, it's reliably call for help, right? So you want to make sure that even patients who aren't confused, they don't reliably call for help and they get up, you want to know. So those are the only patients we would ever use a bed alarm on, because we need to know when they're going to get up because they don't reliably call for help. So that's part of the assessment. It's very important for nurses that we have good reliability, integrated reliability with nurses doing the scale. And then we want to educate nurses about the 3-step fall prevention process. What we've found in the research about, space intervention like this, reducing only 22% of falls, and really believing that if we engage the patients more, if they really understand why they're at risk, if they really understand the interventions, they can help us implement the plan. So it does take education for the staff. It takes modeling. So what we have a training program. So when we implement even the paper tool, we have a training program, a CE program that we do, where we review the fall risk assessment, and then we give them case studies, and they actually complete the plan based on the case studies, and we talk through how this would be done with a patient. But that's an excellent question, and it does take modeling. It's going to take time before I think we consistently incorporate this type of patient engagement in our practice. It's something I think we have to do.
One other question. Do you do an assessment every shift? And you do an assessment, do you do the same level of assessment every shift?
In our hospital, the policy is that they do fall risk assessment every shift. We ask that they do, the policy for the patient tool is that they do it on admission. They remind that they check it every day with the patient, remind the patient about it, and then only if it changes do they actually go in. Like if the interventions change, they would update them. But otherwise, they would point to it and say, oh, remember, this is your fall risk. So this is placed on the wall in the patient's room. There's a arrow on the back, and so they, point out what the plan is and point out their risk factors each day so that patients are reminded. And when the family comes in, they use it as a teaching tool with the family. So yeah, we really want your mom to call for help before getting up, or we have the bed alarm on because your mom hasn't consistently been calling for help, and we really think she needs help to get up safely.
I can ask one final question. Mm-hmm. Please, for patients alert and oriented and not your confused patient, do you do any contracting with those patients? Those are the ones that, you tell, please call for assistance, and you walk outside the bathroom for privacy, and they refuse to use the call light and then fall.
Mm-hmm. We don't use that here, but I think that like this is a kind of a contract. I think we had talked about contracting actually when we were developing the fall tips intervention, because a lot of nurses thought that would make a difference, and I think it would make a difference with some patients, but the problem is some nurses were really opposed to it. They thought that, it was like too heavy-handed. So, I think if you have a process where you are engaging the patient with doing the risk assessment and really are engaging them with identifying interventions, and you get agreement with them that they'll help you carry that out. It's a form of contract. You're not making them sign anything,
Right.
but you are completing it with them, being in their room, you're reinforcing it. It's sort of heavy-handed as having a contract that they sign, but it's the same sort of process.
Right. Much.
So, any hospitals who are on right now who actually employ other strategies or something similar to this in engaging patients? That'd be willing to share?
This is
Kate Walsh has this question.
Yeah, this is Kate, and so we do have a fall promise. People do not sign it, but I could actually send it to you if you want to share it.
Sure.
And it kind of goes over some principles. I just want to say to Patty, loved your lecture. Thank you. Also with TeachBack, we're doing a lot with TeachBack, so it's not just educating the patient and family, but actually asking them to present that material back so they understand how it pertains to them. What we're finding is you can educate, but a lot of times they forget, so they have to think of other ways that you're going to deal with the situation, you know, and then also you can see like how well they are in being able to incorporate it or understand what it means to them. So that's something that we're definitely doing a whole on things, not just fall prevention, but medication, all of that on the TeachBack method.
Right. That's a great point, a great way to ensure that patients actually are able to understand what you've shared with them, is to have them teach it back, or, you know, tell you back in their own words what you went over with them. Now, one question, I guess, sort of along those lines, Patty, or anyone else who's on the line, how do you deal, I know you have a Spanish translation of your tool for acting with patients, but what about patients who, you know, have limited health literacy or, you know, just don't even really understand, may have and, you know, obviously they're in the hospital, they're compromised already. You know, how do you deal with different types of patients at different places, have different levels of understanding or even ability to communicate? You engage the patients, but, I mean, the patient's families.
All tools you would definitely have to have it at, I can't remember what the term is, but, you know, a language of like, I think it's 4th grade or something like that. Like,
level.
So level that has to be for education, and I think that's what most hospitals do. They don't put anything out higher than that level. So.
Yeah, with our tools, we actually do health literacy testing with patients. So, for example, with our paper tool, we actually tested the icons and then also the simple text that we put with them to make sure that patients actually understood what they meant.
What do you do in situations where a patient doesn't speak English or Spanish? Do you have to bring in a translator to engage in those conversations?
And we have that available for any language. So if there isn't a person, there's a phone number that nurses can use and make call to use it. But we do use translation for patients who can't understand English or Spanish.
So, again, just going back to the question about how other hospitals that are in this program are, you know, what are some strategies, if anyone would be willing to share, that you are using to work with patients? And do the majority of the hospitals, is it sort of standard protocol that the more scale is completed with the patient? Just curious from the hospitals that are online. Anyone? No takers? Any other questions from anyone? Okay, well, I think then we have come to the top of the hour, so I know we've gone over in the past. So, Patty, would you mind just scrolling through to the next slide? I just want to, first of all, thank Patty again for her presentation. I think the research that you are doing there is really outstanding. And if there are any related tools that you're able to share, I know, Patty, in your presentation, there were a couple of slides where you had animation and several of the shots didn't come through. I guess if it's okay with you, I'd like to be able to share those missing slides with the hospital so that they can get a visual of those things that you were describing.
Yeah, I agree. I missed them myself. I didn't.
Well, it was the animation that didn't come through in the presentation, but so we can share that with the hospital so they have an opportunity to see it, and then if there's any additional information you want to share about the fall tips that we can circulate to the hospitals, that would be great. But thank you so much for taking time today to do this webinar. And I just want to remind everyone that next month we're going to be doing a webinar on creating and using control charts, monitor your fall metrics over periods of time. And also, just one last reminder, please complete the webinar evaluation form that is available as you exit the webinar today. And thank you all again for coming, and I hope that you found the information valuable. Thank you so much, Patty.
Thank you, Michelle. Thank you, everyone. Bye.
Bye.
Okay. Bye.
Thank you so much.